one and all. Today our topic is hyperemesis gravidarum. This is the most easiest topic we know of in obstetrics and gynecology. And as we know, morning sickness is vomiting in pregnancy. That is, it occurs in 70 to 80% of all pregnancies, and it starts around 4 to 7 weeks, and it is spontaneously subsides by 14th week in 50 to 50% of the cases, while in 90% of the cases it is subsides in the second trimester, that is around 22nd week of pregnancy, and in 10% of the cases it continues throughout the pregnancy. And most of the women have nausea throughout their day, contrary to the term morning sickness. They will have nausea and vomiting throughout the day. So, what is the definition of our hyperemesis gravidarum? It is a severe type of vomiting in pregnancy where the woman is unable to tolerate anything orally. So she can't take anything orally, and which causes deleterious effects on the health of the mother and or incapacitates her day-to-day activities. Whereas in vomiting in pregnancy, she can do her day-to-day activities and she can tolerate anything orally. But here, she can't tolerate anything orally, and where she lands in starvation, it causes deleterious effects on the health of mother, and it incapacitates her day-to-day routine activities. So incidence is 0.3 to 1.5%, whereas vomiting in pregnancy is 70 to 80%. So what is the criteria for defining hyperemesis gravidarum? That is persistent vomiting resulting in dehydration and weight loss of more than 3 kg or 5% of the body weight, and starvation leading to electrolyte imbalance and ketonuria. So there are 4 criteria for diagnosis of hyperemesis gravidarum. That is persistent vomiting leading to dehydration and starvation leading to weight loss, and electrolyte imbalance and ketonuria. So this is the same. The adverse effects of severe vomitings are dehydration, metabolic acidosis because of starvation or alkalosis, because of loss of hypochloric acid. Hypochloric acid HCl hydrochloric acid HCl is present in the stomach juices. So which gets vomited, which gets excreted out through vomiters. So whereby acidic loss is present and she lands up in alkalosis, or there might be electrolyte imbalance because hypokalemia may be present because of renal loss of potassium, and she may have weight loss because of starvation. So the adverse effects are dehydration, metabolic acidosis or alkalosis, and electrolyte imbalance, mostly hypokalemia, and weight loss. So what is the incidence? There has been marked fall in the incidence during the last 30 years. It is now a rarity in the hospital practice, that is less than 1 in 1,000 care pregnancies, whereas we have seen incidences 0.5 to 1.5%, whereas now it is decreased. It is because of better application of family planning knowledge, which reduces the number of unplanned pregnancies, and the early visit to antenatal clinic, whereby we can treat the patient with the level of nausea itself, and potential antihistaminic and anti-emetic agents which are available. And what is the etiology? So our hyperemesis gravidarum is multifactorial in origin, and the etiology is exactly not known. So what are the probable causes? The etiology is obscure, but the following are the known facts. It is mostly limited to the first trimester of pregnancy, and only in 20% of the cases it extends till second trimester. And it is more common in first pregnancy with a tendency to recur again in the second pregnancy. So during second pregnancies or subsequent pregnancies, the incidence of hyperemesis gravidarum decreases. And age is not clearly known, but younger age might be a risk factor, and low body mass. A patient who has low body mass prior to preconceptionally, and it may lead to hyperemesis, and history of motion sickness or migraine. And if there is any family history, that is mother and sisters may also suffer from the same manifestation. And it is most prevalent in hereditary form more and in multiple pregnancies, where HCG is more. It is more common in unplanned pregnancies, but much less amongst the ill-estimated ones. And women with hyperemesis gravidarum often suffer from transient hypothyroidism, that is clinical or subclinical. So what is the etiology? It is usually limited to first trimester, younger age group, and low body mass index. Patients usually have low tendency to eat, and she might have acid peptic diseases prior to pregnancy, and she may have low body mass index, and she may have history of motion sickness or migraine, and she may have family history and raised HCG as in cases of hereditary form mode and multiple pregnancy, and it is more common in unplanned pregnancy, but it is less common among the illegitimate ones. So what are the theories? What might be the probable cause of hyperemesis gravidarum? Theories are hormonal. So amongst the hormonal, first one most important is excess of chorionic gonadotropin or high biological activity of human chorionic gonadotropin. So this is proved by the frequency of vomiting at the peak level of HCG. That is, peak level of HCG is is highest in early morning, in early hours of the morning. So we do pregnancy test to confirm pregnancy. We do urine pregnancy test in the first voided urine. As soon as the woman wakes up from the bed, from the first voided urine, if we do urine pregnancy test, then chance of getting positive results are more. And this is proved by the frequency of vomiting is also more during early morning. So highest peak of HCG occurs in the morning, and vomiting is also occurring more in the morning. So this HCG might be the cause. And also the increased association with hereditary form mode and hyperemesis gravidarum is in increased association with hereditary form mode, multiple pregnancy, Down syndrome, hydroxypitalis, where HCG titers are very much raised. So HCG is very much raised in hereditary form mode or molar pregnancy, multiple pregnancy, because two fetuses are present, and in Down syndrome and in hydroxypitalis. In these cases, HCG titer is more, and in these cases, mother presents with hyperemesis gravidarum or increased sensation of vomiting. And a high serum level of estrogen may also be related, but if there is contradictory to this, estrogen level increases throughout the pregnancy. In first trimester it is low, in second trimester it increases, and in third trimester it is even more. But vomiting subsides after first trimester, usually decreases after first trimester of pregnancy. So this association is questionable. But high serum level of estrogen might have increased chance of hyperemesis gravidarum, because in female fetuses, if the mother is carrying a female baby, then she has higher chances of more of vomitings during pregnancy. And progesterone excess. Progesterone excess causes relaxation of the cardiac sphincter of the stomach, and it causes simultaneous retention of the gastric fluids due to impaired gastric motility. So relaxation of the cardiac sphincter, and because of impaired gastric motility, the secretions, gastric fluids are retained within the stomach, which may in turn cause GERD or vomiting. So other hormones which are involved are thyroxine, prolactin, leptin, adrenocorticotropic hormones, and growth hormone, of which thyroxine and growth hormone are most important. So psychogenic, this is the most important cause, and it probably aggravates nausea once it begins. So if the patient has nausea, because of psychological factors, she may end up in recurrent vomitings. And neurological ending. What is the difference between neurological and psychological? Psychological is she feels the sensation repeatedly, and in neurological element, the surroundings affect. Like if the patient subsidence after shifting of the patient from home surroundings. If the patient is shifted from the home surroundings to hospital surroundings, she may, without any other difference in the diet or the medical management, she usually does good. Because of the neurological element, or patient might be suffering from conversion disorder or somatization or excess perception of sensations by the mother or other theories. And dietary deficiencies. These dietary deficiency might be the cause or might be the result of our hyperemesis gravidarum. Because because patient might have low body mass, and because of low carbohydrate reserve, it happens after a night without food. Because of low body mass, low body weight, and she has low body carbohydrate reserve, which in turn might be the cause for increased vomiting during pregnancy, or a night without food. That is, patient will be having low carbohydrate diet, low carbohydrate reserve, and in the next morning, because of which she may present with vomiting, because throughout the night she will be in starvation. And deficiency of vitamin B6, that is pyridoxine, B1 thiamine, and protease may be the effect rather than the cause. So vitamin B6 deficiency also causes hyperemesis gravidarum, and vitamin B6 deficiency is also the result of hyperemesis gravidarum. So what are other causes? That is allergic or immunological basis and H. pylori infection. That is pre-existing GERD or peptic ulcer. And there might be decreased gastric motility as is found to cause nausea. So decreased gastric motility may also be the cause of nausea. So whatever may be the cause of initiation of vomiting, it is probably elevated by the neurological element. That is because of the surroundings. Unless it is not quickly rectified, so others like complications like dehydration, carbohydrates, starvation, supervision, and a vicious cycle of vomiting appears. That is because of vomiting, there is carbohydrate starvation and there is ketosis. Ketosis, which in turn leads to vomiting. So there is no specific, what is the pathology? There were no specific morbid anatomical findings. The changes in the various organs are described by Sheehan. These are the pathological changes what we see in hyperemesis gravidarum are not specific to hyperemesis gravidarum, but these are the manifestations of starvation and severe malnutrition. So what is the pathology? In liver enzymes are elevated and there is centrilobular fatty infiltration without any necrosis. So there is centrilobular fatty infiltration without any necrosis. And kidneys are usually normal and there is occasional findings of fatty changes in the cells of the first convoluted tubule which may be related to acidosis. So kidneys are usually normal and there is occasional findings of fatty changes in the cells of first convoluted tubule. A a small heart is a consistent finding and there might be subendocardial hemorrhage. And in brain, there might be small hemorrhages in the hypothalamic region, which is known as Wernicke's encephalopathy. And the lesions may be related to vitamin B1 deficiency, that is thiamine deficiency. So in the liver, there is centrilobular fatty infiltration, and in kidneys, there is occasional findings of fatty changes. So in both liver and the kidney, there are fatty changes, and in both heart and the brain, there are hemorrhagic findings. In heart, there is subendocardial hemorrhage, and in brain, there is small hemorrhages because of Wernicke's encephalopathy, which is because of vitamin B1 deficiency. So what are the metabolic, biochemical and circulatory changes we find in hyperemesis gravidarum? Because there is both starvation and dehydration which are due to vomiting, the following metabolic changes occur. Because of inadequate intake of food results in glycogen depletion. Glycogen stores in the body are depleted. For the energy supply, the fat reserve is broken down. So glycogen carbohydrate is deficient, so fat reserves are broken down. Due to low carbohydrate, there is incomplete oxidation of the fatty acids and there is accumulation of ketone bodies in the body. So ultimately, ketone bodies gets accumulated in the body and results in ketosis. The acetone is ultimately excreted through the kidneys and in the blood. So what are the ketone bodies we know of? One of it is acetone. So acetone is ultimately excreted through the kidneys and in the blood. There is also increase in endogenous tissue protein metabolism resulting in excessive excretion of the non-protein nitrogen in the urine. So endogenous tissue protein, so fat is being metabolized and also tissue protein is also being metabolized. So it results in excess of non-protein nitrogen excreted in the urine. So water and electrolyte imbalance is serious, metabolism is seriously affected leading to biochemical and circulatory changes. So what are the biochemical changes we know of? Acidosis because of starvation, because of ketoacidosis might be present, and alkalosis. Alkalosis is because of loss of hydrochloric acid HCl from the blood, and hypokalemia is the most common metabolic abnormality seen in hyperemesis gravidarum. So loss of so how does hypokalemia occur? It is like during vomiting there is loss of both H plus and chloride, H plus and chlorine from the due to vomitus, and which leads to excretion of H plus ions in the urine. To compensate it, sodium hyponatremia first occurs. That is loss of sodium ions through the urine occurs, through kidneys occurs, and to compensate it, body potassium is lost. So ultimately we land up in hypokalemia. This is the most common clinical pathology seen in hyperemesis gravidarum. So what we see is hypokalemia. So during treatment also we need to rectify this hypokalemia. So loss of water and salts in the vomitus results in falling plasma sodium, potassium and chlorides, and urinary chloride is well below the normal or may even be absent. Hepatic dysfunction results in ketosis with the rise of blood urea and uric acid. And patient suffers from hypoglycemia, hyperproteinemia, and hypervitaminosis. So, what are the biochemical changes we find? Metabolic acidosis and metabolic alkalosis. Acidosis is due to starvation, alkalosis because of loss of gastric fluids. And there is hepatic dysfunction results in ketosis because of carbohydrate loss, less carbohydrate and breakdown of the fatty acids results in ketosis, and patient may suffer from both hypoglycemia because of nutritional deficiencies like hypoglycemia, hyperproteinemia, and hypervitaminosis. What are the circulatory changes? Because of dehydration, patient lands up in hemo concentration. It results in rise in hemoglobin percentage, RBC count, and hematocrit values. Slight increase in the white cell count with increase in eosinophils may also occur. There is concomitant reduction of the extracellular fluid. What is the clinical course? For the management and prognostic point of view, the cases are grouped into early and late. Late is moderate to severe. The patient is usually a nullipara in early pregnancy, and it occurs in early pregnancy, and the onset is insidious. So it may be divided into early and late. Early is mild and late is moderate and severe. Patient is usually, it affects more in the first pregnancy than in second pregnancy, and it is more in the early pregnancy, and its onset is insidious. So what are in early stage, vomiting occurs throughout the day and normal day-to-day activities are not curtailed, and there is no evidence of dehydration or starvation. So this is simple vomiting in pregnancy. In late stages, there is evidence of starvation and dehydration. This is hyperemesis gravidarum. So what are the symptoms? Vomiting is increased in frequency with retching, and urine quantity is diminished even to the stage of oliguria. Because of dehydration, urine quantity is also decreased, and there might be epigastric pain because of decreased gastric secretion, and the constipation may occur because of dehydration, and constipation may occur, and complications may appear if not treated at earlier stage. So what are the signs? Signs features of dehydration are dry coated tongue, sunken eyes, acetone in the smell, because of ketosis, acetone is produced and which is released to the lungs. So there will be acetone smell in the breath or fruity smell in the breath is present. Dry coated tongue and sunken eyes are a result of dehydration. And tachycardia and hypotension because of dehydration might be present. And the rise of temperature might be noted. It is not consistent, but temperature, mild increase of temperature, low-grade fever might be present. And jaundice is a late feature because of hepatic dysfunction. Because of fatty changes in the liver, jaundice may occur, but it is very late feature and is very rarely seen. On vaginal examination, ultrasonography is done to confirm the diagnosis. So what are the signs? These are the signs of just dehydration. That is dry coated tongue, sunken eyes, tachycardia, hypotension, and hypothermia may be present. And acetone in the smell is because it is due to starvation because of breakdown of the fatty acids. Acetone and ketone bodies might be present, which are excreted through respiratory system, and acetone smell in the breath or fruity smell in the breath may be present. Vaginal examination, ultrasonography are used to confirm the diagnosis, that is pregnancy. So what are the investigations we do? Urine analysis is done. Complete urine examination is done. Quantity is small. Oliguria might be present because of dehydration, and because of concentration of the concentrated urine might be present, which is dark in color, and there might be high specific gravity with acid reaction. High specific gravity of the urine might be present because of acid reaction, because H plus is excreted through the urine. And presence of acetone or occasional acetone, that is ketone bodies might be present in the urine, and occasional presence of protein and daily bile pigments may be present. So presence of acetone is very significant, which requires hospital admission, even if the patient has no other complaints like absence, or like she has no limitation of day-to-day activities. Even then, if there is ketone bodies, that is acetone in the urine, then patient has to get admitted, because she is going into ketoacidosis and she will land up in metabolic acidosis, which we should not go with. And diminished or even absence of chloride may be present in the urine. What are the biochemical and circulatory changes? There is routine and periodic estimation of the serum electrolytes, that is sodium, potassium, and chloride is helpful in the management of this case. And serum, so protein and periodic estimation of serum electrolytes must be done because metabolic alterations happen in hyperemesis gravidarum. So periodic assessment has to be done and it has to be corrected. And there might be transient thyroid dysfunction during hyperemesis gravidarum. So we have to do serum TSH, T3 and free T4. Women may suffer from transient phase of thyroid dysfunction. It might be critical or subclinical. So we have to do thyroid profile and we have to correct it. And ophthalmic examination is done if the patient is seriously ill. And we have seen in brain and in heart hemorrhages occur. In brain there might be aortic encephalopathy and in heart subendocardial hemorrhage might be present. So in severe cases retinal hemorrhage might be present and detachment of the retina might be present because of dehydration. These two might present, retinal hemorrhages and detachment of the retina. And ECG changes may occur because of alteration in the electrolytes in the body because of hypokalemia, and that is abnormal sodium serum potassium level. ECG changes may occur. So what is the differential diagnosis? So usually patient presents with vomiting and we don't know whether she's pregnant or not. So first we have to confirm the diagnosis. So what are the other probable causes of vomiting in young female? Like presenting with vomiting, we have to note the other causes. So when vomiting is persistent in spite of usual treatment, other causes of severe vomiting, medical or surgical, should be considered and investigated. So what are the medical and surgical causes of vomiting? Those are appendicitis, gastroenteritis, intestinal obstruction, gynecological causes are twisted ovarian cyst, and other surgical are cerebral tumor, pyelitis, and uremia. What is the diagnosis? So the pregnancy should be confirmed first. Usually presence in the first trimester. By that time pregnancy might be confirmed or not. So pregnancy must be confirmed by urine pregnancy test and or by ultrasonography. And all the associated causes of vomiting are to be excluded. So to diagnosis, ultrasonography is not used. Diagnosis of pregnancy is done by urine pregnancy test. Ultrasonography is just a confirmatory test. So ultrasonography is used to confirm the pregnancy and to exclude the other causes, that is obstetric causes like hereditary form, mole or multiple pregnancy, or gynecological causes like twisted ovarian cyst, and surgical or other medical causes causing vomiting. So what we do is for diagnosis, pregnancy is confirmed, and then ultrasonography to confirm the diagnosis and to rule out the other causes of vomiting. So what are the complications? So what are the investigations we do? That is urine analysis and serum electrolytes, ultrasonography, and urine pregnancy test. So what are the complications? Due to the effects of complications are big pathologies because of starvation, and our complications are because of dehydration and starvation, which result in ketoacidosis. The following complications may occur, which are fortunately rare nowadays. So what are the neurologic complications? Wernicke's encephalopathy, beriberi due to thiamine deficiency or B1 deficiency, and pontine myelinosis may occur, peripheral neuritis may occur, psychosis may occur, and stress ulcers in the stomach, and esophageal tear, that is malady Weis tear may occur because of excessive retching. Retching means it causes at the lower end of the esophagus, mucosal tears may occur, which result in malady Weis tear syndrome. And jaundice and hepatic failure may occur. Convulsions and coma may occur. Hypochlorothrombonemia might occur due to vitamin K deficiency and renal failure. What are effects on the fetus? Fetus usually remains unaffected once the problem is resolved. So there is no deleterious effect on the fetus because it occurs early in the pregnancy. But fetal risks might be because of low birth weight. That is, if vomiting persist throughout the pregnancy, dietary intake will be low, and baby might suffer with low birth weight and its complications. But as such, hyperemesis has no effect on the baby. So how do you prevent? Prevention is the effective management to correct simple vomiting of pregnancy. So at early stages, we have to correct vomiting in pregnancy, and we should not let the patient to go into dehydration and starvation. So thus we can prevent hyperemesis gravidarum. So what is the management? The principles in the management are maintenance of hydration. Maintenance of hydration to control vomiting, correct fluids and electrolyte imbalance, and to correct metabolic disturbances, that is acidosis or alkalosis, to prevent serious complications of severe vomiting and care of pregnancy. So the principles in the management are management of dehydration, maintenance of dehydration must be maintained, and first vomiting should be controlled, and fluid and electrolyte imbalance should be corrected, and metabolic disturbances should be corrected like acidosis and acidosis, and severe complications of vomiting should be corrected, and general antenatal care of the pregnancy should be taken. And what are the modes of management? What we know are dietetic and lifestyle changes, and the second one is drug therapy. So what is the diet? When the sickness has well-defined morning instance, the time-honored piece of toast or biscuit is taken 30 to 45 minutes before rising from the bed. It may be useful. So what we do is in the vomiting, in simple vomiting in pregnancy, patient is advised to take carbohydrate diet, that is toasted bread or a biscuit 30 to 45 minutes. Just she gets up from the 30 to 45 minutes before she gets up from the bed, so that she might be relieved from that vomiting and nausea. And at first, dry carbohydrate foods like biscuits, bread, and toast are given. Small but frequent feeds are recommended in moments of with vomiting in pregnancy. We should avoid spicy and fatty food because spicy food causes gastritis and increased gastric acid secretion, whereas fatty food has prolonged gastric emptying time, whereby gastric distension and vomiting might occur. And periconception, because vitamin deficiency might also be the cause. So periconception vitamin supplementation has to be given. Vitamin supplements we need a B1, B6, B12, and vitamin C. So what are the other non-pharmacological methods we know? That is acupuncture, acupressure, and ginger capsules. Acupressure is at P6 or I don't know what it is, Newton point, 3 finger breaths, which is 3 finger breaths above the wrist. We have to put acupressure. That is the acupressure point, which decreases vomiting in pregnancy. So these dietary modifications are required to manage vomiting in pregnancy. Hospitalization. Whenever a patient is diagnosed as a case of hyperemesis gravidarum, so when is hospitalization required? That is when patient is diagnosed as hyperemesis gravidarum, or vomiting is not controlled with drugs, or there are signs of dehydration or ketonuria, patient is admitted to the hospital. So when there is hyperemesis gravidarum or vomiting is uncontrolled and there are signs of dehydration and starvation. Starvation is or ketonuria. When these are present, she is admitted to the hospital. Surprisingly, with the same diet and the drugs used at home, the patient improves rapidly. The relatives may be too sympathetic or too indifferent. So the patient, if the environment is changed, she might improve. Fluids, oral feeding is Oral feeding is withheld for at least 24 hours after cessation of vomiting. So, in hyperemesis gravidarum, we have to stop oral feeding because it aggravates vomiting, and in turn, patient with vomiting, it results in dehydration and the cycle continues. So, oral feeding is withheld for at least 24 hours after the cessation of vomiting. So, we have to stop anything given orally for 24 hours after cessation of vomiting. And the basis of treatment is intravenous hydration, vitamin supplementation, and anti-emetic drugs. So what is the basis is we have to dehydration has to become corrected, and vomiting has to be stopped, and vitamin supplementation has to be given. And we also should correct serum electrolytes. The serum electrolytes should be estimated and corrected if there is any abnormality. What is IV hydration? So during this period, fluid is given through intravenous drip method only, and she is not allowed anything orally. So what is the amount of fluid to be infused in 24 hours? The total amount of the fluid required is 3 liters plus the extra amount that is lost in the vomitus in urine. So the total amount of the fluid is approximates to about 3 liters, of which half is given as 5% dextrose and the other half is given as ringus lactate. So it is around 3 liters, half of which is given as 5% dextrose and half of which is given as ringus lactate. So the extra amount of crystalloids is equal to the amount of vomitus in the urine in 24 hours is to be added. So the extra amount of fluid that is lost in vomitus in the urine has to be added to this 3 liters. With this, Dehydration, ketoacidosis, water and electrolyte imbalance are likely to be rectified. Dehydration will be corrected as we are giving crystalloids, and ketosis will be given as we are giving 5% dextrose which contains carbohydrate. So fatty acid metabolism will be decreased. Water is given, and because lactate it contains water and electrolyte imbalance will be corrected because we are giving the electrolytes also in because lactate. So all these will be corrected. That is dehydration, ketoacidosis because of starvation, water and electrolyte imbalance, water and electrolyte imbalance because of vomitings. And serum electrolyte should be estimated and corrected. So what we know is most common electrolyte abnormality we see in hyperemesis gravidarum is decreased potassium. That is hypokalemia. Potassium may be added if there is any hypokalemia on estimation of serum electrolytes. And enteral nutrition through nasogastric tube may also be given. So if patient has severe nausea, they may do enteral nutrition through NG tube, nasogastric tube feeding we might argue, or total parenteral nutrition may be tried, but TPN has its own risk factors, so it is avoided mostly in pregnancy. And vitamin supplementation. So what are all the vitamin supplementation we give of B1, B6, B12 and vitamin C. And B1 is thiamine, B6 is pyridoxine and B12 is methylcobalamin. And these three can be added in the intravenous drip, that is in IV infusion, that is we give D5 and RL, in which we can add vitamin B1, B6 or B12, and the daily dose of thiamine required is 100 milligrams per day. And vitamin C supplementation, oral supplementation can be given. So drugs. What are the drugs we know of? For treating any nausea and vomiting? The first line drug for any non-pregnant women, what we usually do is ondansetron. But here it comes in the category B drug, that is second line drug. And our first line drug is doxylamine and pyridoxine vitamin B6 supplementation. So our first line drug, that is FDA class A drug, is doxylamine 10 mg, and pyridoxine vitamin B6 is also said to decrease nausea and vomitings in pregnancy. So along with doxylamine will give pyridoxine. This is the first line drug. And if the vomitings does not subside with doxylamine and pyridoxine, then we will go for this class B drugs. Those are ondansetron, metoclopramide, diphenhydramine and meclizine. And the other class 4 drugs are promethazine, that is Finalga, or prochlorperazine, that is Temkin 5 mg, or triflupromazine, that is Ciclin 10 mg. They may be administered twice or thrice daily intramuscularly. Class C drugs may be administered twice or thrice daily intramuscularly. So class 1 is first line is doxylamine plus pyridoxine, and second line of drugs are on what we know commonly used are ondansetron and metoclopramide, and class C Finalga we know commonly used for sedation, that is Finalga, or prochlorperazine statin, which is usually used in migraine and venous disease, or triflupromazine, that is CP. These may be administered intramuscularly. So class 1 is doxylamine, class 2, class A is doxylamine, class B are ondansetron and metoclopramide, and class C is promethazine or Finalgan, or prochlorperazine or triflupromazine. So trifluperazine, that is espazine, is 1 mg twice daily intramuscularly, is a potent anti-emetic drug, and metoclopramide along with ondansetron is class B drug. So what is the action? Metoclopramide stimulates gastric and intestinal motility without stimulating the secretions. So it increases the gastric motility, whereby it is useful in decreasing the vomitings. And the others we use are H2 receptor antagonists, ranitidine or famotidine may be used. Because patient suffers with heartburn, so we may use ranitidine or famotidine. And hydrocortisone 100 mg. So the other drugs are steroids. Steroids are hydrocortisone 100 mg IV injected is given in case of hypertension and in intractable vomiting. And the oral method prednisolone is also used in severe cases. So what are the drugs we know of? Those are anti-emetic drugs, that is doxylamine, class B ondansetron, metoclopramide, class C is Finalgan or prochlorperazine, and H2 receptor antagonists are ranitidine and famotidine, and the steroids are hydrocortisone and prednisone. So other treatment is nursing care. Sympathetic but firm handling of the patient is essential by the relatives, but social and psychological support should be extended to the patient. So hyperemesis progress chart. What if the patient is admitted to the hospital? Daily record of pulse rate, temperature, and blood pressure at least twice daily, 2 times a day. Recording of pulse rate, temperature, and blood pressure, an input output chart, that is the amount of fluid patient is taking orally or given intravenously, and the amount of fluid lost from the body. So all we can calculate is urine output and around 300 to 500 of other body losses of water. This must be monitored, and urine for H1 protein and bile might be estimated, and blood biochemistry and ECG when serum potassium is abnormal or important. It is helpful to assess the patient. It is helpful to assess the progress of the patient while in the hospital. So our hyperemesis progress chart is helpful to assess the progress of the patient while in the hospital. So, what are the clinical features of improvement of the patient? That is, first that is subsidence of vomiting, and patient feels hunger. That is, there won't be any nausea. Nausea will be decreased, and patient feels hunger, and the patient has better look. That is, there won't be any sunken eyes or dry coated tongue. Patient has a better look, and there will be normalization of blood biochemistry. That is, the electrolytes will be normal. Hypokalemia does not exist, and the disappearance of the estrone from the blood in the urine. Because of fatty acid metabolism, estrone is increased in the body. While if we correct fatty acid metabolism and if we give carbohydrate supplementation, then estrone will be decreased, which is excreted both in the blood, which gives fruity odor, and in the urine, which gives ketone bodies positive in the urine. And normal pulse and blood pressure will retain. The patient might have tachycardia and hypertension because of dehydration and hyperemesis gravidarum, which becomes normal. That is, normal pulse and blood pressure will be present. Albumin will be corrected, and patient will have normal urine output. So diet. So that is first initiation of carbohydrate diet. Diet was discussed. That is for the excessive vomitings in pregnancy. So when we wean off the patient from intravenous fluids towards the diet in hyperemesis gravidarum, this is the slide indicating it. So before the intravenous fluid is omitted, the food is given orally. Foods are given orally. At first, dry carbohydrate foods like biscuits, bread, and toast are given. Small but frequent feeds are recommended. And gradually, full diet is switched in patient with hyperemesis gravidarum. And termination of pregnancy is rarely indicated. And intractable hyperemesis gravidarum, in spite of therapy, is rare these days. And the only indication for termination of pregnancy is intractable hyperemesis gravidarum. So vomiting in late pregnancy. Usually in 70 to 80% of the cases, hyperemesis vomiting in pregnancy usually decreases by the first trimester. That is around 14 weeks of pregnancy. But here it may last till 20 weeks. In 20% it may last till 22 weeks, and in 10% it exists throughout the pregnancy. But we have in later pregnancy, we have to differentiate this vomiting in late pregnancy with other causes of vomiting in pregnancy. So the most common causes are acute liver failure, urinary tract infection, preeclamptic toxemia, acute hyperemesis. The non-obstetric causes are gastroenteritis, cholecystitis, intestinal obstruction, appendicitis, and regeneration of fibroids. So summary is definition of hyperemesis is patient takes nil orally with loss of weight and metabolic changes and ketonuria. These are because of starvation, and patient does not take anything orally. So what is the etiology? It is multifactorial. That is age, younger age, and early parity, like the first pregnancy, and family history of mother or sister having hyperemesis. Or the other theory is hormonal because of high increased HCG, or others like growth hormone, estrogen, progesterone, thyroxine, prolactin, leptin, adrenocortical hormones, adrenocortical hormones, they are not corticotropic, adrenocortical hormones. And other causes are psychogenic and neurogenic, and nutritional deficiency like B6 deficiency might be present. So our first line of management in For vomiting in pregnancy or hyperemesis or doxylamine plus pyridoxine, that is vitamin B6. So what is pathology and treatment? Dehydration has to be corrected. That is through IV fluids. 3 liters of IV fluids. Half is 5% dextrose and half is liquorous lactate. Starvation. Because of starvation, there is increased ketone bodies. Like metabolic changes leads to hypokalemia. So we add potassium to the intravenous strip and hypertension might be present. And there might be hypoconcentration, hypovitaminosis, hypoproteinemia. Vomitings, that is drugs. As we know, first line is doxylamine and pyridoxine, and second line of treatment is ondansetron and metoclopramide, and third line of management is phenylephrine. So, what is the just to brief you about how does ketosis occur in the body? So, because of fasting, that is starvation. Because of fasting, starvation, there is glycogen depletion. That is glycogen depletion. Glycogen stores at first decrease, and like carbohydrate metabolism occurs. So, glucose metabolism occurs, and fats are broken down. Fatty acids are broken down, and proteins are also broken down to amino acids. So fats are broken into fatty acids and proteins are broken down into amino acids. In starvation state, so in starvation state, in the early days of starvation, fatty acid is converted into acetyl CoA, and the acetyl CoA goes into Krebs cycle. Krebs cycle in turn produces ATP. But because of in prolonged increased acetyl CoA and increased ATP occurs, but if the starvation is prolonged, acetyl CoA is increased, very much increased, so that auto regulation of the fatty acids is decreased, and so there is excess of acetyl CoA in the body. So increase of ATP in the body slows down ETC, and which in NADH is reduced, that is reduction is reduced and Krebs cycle is inhibited. So this will result in NADH and resulting in slowdown of the Krebs cycle. So now the acetyl CoA is in turn increased within the body. So excess of acetyl CoA is converted in the liver into ketones. So one of the ketone we know is acetone. It is converted into ketones, and ketones reach all tissues of the body, including brain, via the blood-brain barrier. So now the patient lands up in ketoacidosis or metabolic acidosis. So we should prevent this step, and we have to give intravenous fluids, that is dextrose has to be given. Along with it, to correct electrolyte imbalance, we have to give ringus lactate. So ketosis is a metabolic state where the liver produces small organic molecules called as ketone bodies. These ketone bodies get accumulated in the brain and all other tissues of the body, resulting in acidosis. They have acidic in nature, so this must be done. So thank you.